And well, welcome everybody, especially to the speakers that have accepted our invitation to take part of this forum, and also to all the participants that have registered for this event and that they are already connected or connecting right now. The objective of this meeting was to put together in the same discussion forum to different representatives of European research projects that are related to atrial fibrillation, together with representatives of patients. And we also have clinicians in the session to give their opinion on the topic. And the objective is to discuss between these different therapies that are available, the therapies that are under research in the research group involved in these different research projects, and together again with the clinicians and with the patients that are finally the final goal of all these projects and all of this research is to improve the quality of life of patients. That should be always the overall goal of all our research in the field. So in this event, we will have, it's basically thought as a roundtable, and we will have basically 3 speakers and myself that will be coordinating the session today. First, let me introduce myself. My name is María Guillem, and I work as a professor at Universidad Politécnica de Valencia in Spain. And here I will represent the role as the representative of the consortium Personalized AF, which is a European project that is a Marie Curie ITN. So we are training PhD students in personalization of for atrial. Together, with me, there's also Trudy Loban. She represents the Arrhythmia Alliance, and she will also present the role of the Atrial Fibrillation Association of Patients. And I will later on, I will present her, and I will leave her the room to talk about what they do in these patient associations. There's also with us Felipe Atienza. He is a clinician. He's a cardiologist at Hospital Gregorio Marañón in Madrid. And he will represent also a project that is called AFFINE, and it's also related to the therapies in atrial fibrillation. And finally, we have Daniel Engler, sorry, not from Universidad Politécnica de Valencia, from Hamburg, and he will present. And he will represent the project AFFECT EU. And let me first start giving an introduction of the speakers. Myself, I'm master's in biomedical engineering and from Northwestern University, and I also did a PhD in electronics at Universidad Politécnica de Valencia. And right now, I'm the deputy director of Itaca Research Institute at Universidad Politécnica de Valencia. I was a Fulbright Fellow at Northwestern University. Currently, I'm associate professor at the Electronic Engineering Department. Well, I have co-authored several scientific research papers and participated in conferences, patents, research projects. And my research interests include the development of medical instrumentation and signal processing for the diagnosis and treatment of cardiac disorders. Trudy Loban, she established the syncope trust and reflex anoxic seizures charity following the diagnosis of her daughter with RIS, and at the request of her pediatric neurologist in 1993. Trudy is an expert in patient representative and advocate who has led the establishment of over 40 heart rhythm organizations worldwide in the past 27 years, working collaboratively with key partners of all backgrounds and disciplines to improve the diagnosis, treatment, and care of both children and adults affected by cardiac arrhythmias and sudden cardiac death. Trudy was instrumental in organizing and campaigning to introduce new standards in the UK for arrhythmias and sudden cardiac death. And Trudy went on to establish the Arrhythmia Alliance, the Heart Rhythm Charity, working together to improve the diagnosis, treatment, and quality of life for those affected by arrhythmias. In 2007, due to the high demand for information and resources in atrial fibrillation, Trudy launched the AF Association. She was recognized for her services to healthcare when being made a member of the British Empire in the Queen's Birthdays Honour list in 2009. She has been runner-up for the Lifetime Achievement Award, Directory of Social Change in 2014, and become Honorary Fellow of the Royal College of Physicians in 2013. We will also have with us, we do have with us, Felipe Atienza from Hospital Gregorio Marañón, Madrid, and he is doctor in medicine from Universidad de Valencia. He made his training as cardiologist at Hospital General Universitario de Valencia and completed his pre- and postdoctoral training at various universities in Great Britain and the United States. In 2001, he completed his master's degree from the subspecialization in cardiac electrophysiology from Universidad Complutense de Madrid. Since 2002, he has been working in the cardiology department of Hospital Gregorio Marañón, where he is clinical chief, research and training coordinator, and professor associate of the Department of Medicine of Universidad Complutense de Madrid. He has given more than 16 vital lectures. He's senior researcher of studies derived from national and international competitive funding. He has co-authored over 100 articles with more than 4,000 citations, and his H index is 31, and has directed 4 PhDs. His main areas of research are atrial fibrillation and sudden death. And in the area of transference, he is co-inventor of 2 patents. And sorry again for this, Daniel. Daniel Engler from Hospital Hamburg is health scientist and project manager and has been actively engaged in the submission and implementation of European and national grants since 2015 at the Research and Transference Center of Hamburg and UKE. He graduated from University Furtwagen and University of Maastricht at the University of Applied Science, Hamburg. He received a bachelor and master's degree in health sciences in European public health. Daniel Engler has been active in the research project management field since 2015 for several national and European funded projects like AFFINE, MMAF, EARTH, and AFFINE. And at present, he's being appointed as health scientist and project manager for the University Health Center Hamburg and being involved in managing local and international research projects in the field of cardiovascular disease. So we are all here together. I will give first an introduction of why we are here. And it's basically because atrial fibrillation is a very frequent arrhythmia. We probably all know about this. It is estimated that about 2% of our population suffers atrial fibrillation, which is many millions of patients in the world. Atrial fibrillation does divide life expectancy by 2, and it costs about 2% of the total annual European health system budget. And one of the problems related with atrial fibrillation, and that's probably why there are so many patients with atrial fibrillation, is because the overall treatment of the patients is inefficient. There are several treatment options, including drugs and control of the rhythm with cardioversion or ablation, and still most of the patients are left uncontrolled, basically because there's no clear option for the patients, or it's not clear what is the best treatment for each of the patients. And most likely patients will jump from one therapy to another, and even surgical interventions, which are the most aggressive one, are not useful in all patients. And it's clear that a new paradigm for treatment of atrial fibrillation is needed. In the treatment of atrial fibrillation, the first thing that has to be done is to prevent the strokes, because strokes are the leading cause of death in patients with atrial fibrillation. And it is recommended to look for what it's called the Chadbach score to decide what is the treatment that should be given for the anticoagulation or to prevent the strokes. It's also an option if the symptoms are severe to restore the sinus rhythm and terminate atrial fibrillation. And there are different options. We can use antiarrhythmic drugs, we can do electrocardioversion, or we can do ablation. And if rhythm control fails, at least the rate should be controlled. And for that, beta blockers can be used to reduce the atrioventricular conductions. To prevent the strokes, which is one of the most important things for patients with atrial fibrillation, it has been defined the Chadbach score that takes into account several points, which are, let's say, the age of the patient, the history of diabetes or vascular disease. According to these points, you make a calculation and you decide whether you should coagulate the patient or the patient should not be anticoagulated. And regarding the restoration of sinus rhythm, when one patient is diagnosed for atrial fibrillation, it's usually called that is paroxysmal if the atrial fibrillation doesn't long for very long. If it lasts for longer, then we call that it's persistent. And if it lasts for longer, we call it long-standing or permanent. And overall, the treatment efficiency is not very good, and this is probably because the guidelines have been changing 1 year after another, and there are different treatment options. And actually, if we want to treat a patient for rhythm with atrial fibrillation, we want to restore sinus rhythm, for instance, we probably would start with one antiarrhythmic drug, and if it doesn't work, we go for another antiarrhythmic drug. And if it doesn't work, then we probably go for catheter ablation. If it doesn't work, then we go for more extensive ablation. And eventually, a patient can end in sinus rhythm, or maybe the patient never reaches sinus rhythm or not for a long time, and then just a rate control strategy is used. And in this selection of what should be the best treatment, sometimes the parameters that are chosen are not dependent that much on the state of the atria of the patient, and it's probably also based on the symptoms or patient choice. And that's the situation today for the treatment of patients with atrial fibrillation. So that's probably why treatments are inefficient, because the guidelines probably are not taking into account with enough emphasis what is the state of the atria of the patients, and that's what we believe. And that's why we started this project that I will present briefly now, which is Personalized AF, what it's called Personalization of Therapies for Atrial Fibrillation, a translational training network. And I will present very briefly in a few minutes what Personalized AF is. So for atrial fibrillation, as I said before, the treatment is not taking into account the evaluation of the state of the atria. And that's why our network aims to change the paradigm of classification and diagnosis of atrial fibrillation, delivering a precision medicine strategy based on the personalized characterization of each atrial substrate and disease manifestation. To do that, we have defined different work packages, of course, but first one would be to characterize or to develop tools to characterize the state of the atria. We will also develop tools to improve the treatment strategy of the patients, and we will also incorporate these things together to build a decision support platform that will help the clinicians to take decisions on how to treat patients. Let me explain a little bit these three work packages. About atrial state characterization, we plan to study the genetics of patients with atrial fibrillation, together with the role of fibrosis at basic research level, but also at patient level, a human level. We want to study the role of cardiac electrophysiology as well, and the work of the role of cardiac mechanics and fluid dynamics in the state of the atria that we want to evaluate in a personalized manner. We also want to help to improve the treatments for atrial fibrillation in basically two directions. One, to improve the development of new drug testing methods. We will develop methods to test drugs in vitro with cardiomyocytes derived from iPS cells. So we can work use this bench work to try and test new drugs. We will also use in silico modeling to test drugs in populations of patients. And we will also study how to improve radiofrequency ablation guidance, and we will work both using in silico models and data from patients. And finally, we want to incorporate all this in a decision support platform. We will take the atrial markers from patients, from different imaging and different recording modalities. We will take into account the outcome of the patients when subjected to different treatments. We will take into account also computer models to augment the amount of data that we have to train this decision support platform. And we will get this decision support platform to be fed with, finally, patient-specific atrial markers with this trained network, and then decide among the different treatment options that we have, which is the one that should be better for a specific patient. And this is the consortium that makes personalized AF. The coordinator are ourselves at Universidad Politécnica de Valencia, but there's also in the network Instituto de Investigación Sanitaria La Fe, there's Simula, University of Oxford, Université de Bordeaux, Karlsruhe Institute for Technology, there's Freiburg Heart Centrum, Università di Bologna, Encardia, Maastricht University, and IDIBABS. And together with us, we have also some other organizations that are ADAS 3D, Beratech for Health, EP Solutions, Genome Scan, Università Oslo, and Cardiocentro Ticino. And this is our consortium, and this is what we plan to do to improve the treatment for patients with atrial fibrillation. And now I will leave the room to Trudy Loban from the Heart Rhythm Alliance to present the point of view of the patients.
Thank you so much, and it's a pleasure and an honour to be invited to present today on behalf of Arrhythmia Alliance and AF Association, two international non-profit organisations that I founded, and with Professor John Camp, who many of you will know as president, as well as other leading clinicians around the world and especially in Europe. So improving treatments for atrial fibrillation, I think we need to take a step back and actually improve the diagnosis of atrial fibrillation, because over a third of patients with AF have yet to be detected and diagnosed. And even if you've seen your doctor, if the AF is coming and going, then it's very difficult to detect. And so we need to look at not just treatments for managing AF, but therapies to reduce AF-related stroke and tools to identify AF. And if we think of the patient who is breathless, feeling exhausted, climbing stairs is too much trouble, they have a pounding in their chest, like drums beating out of their chest, the anxiety, the panic, and yet they don't know what's wrong. And sadly, for many patients, they do not discover anything about atrial fibrillation until it's too late and they've had an AF-related stroke. So we really need to be focusing on the detection, and some simple things we can do is, a campaign for Know Your Pulse, Know Your Heart Rhythm, which is something the charities have been spearheading, and we always focus, especially in November when we host the Global AF Aware Week. If we all became pulse rhythm aware, we would soon become aware of any irregularities. And with modern technology and digital devices, we can capture this and discuss with our doctors. So I think, especially now during this pandemic, which is affecting every country, we should be improving access to the digital technology and encouraging the public to become more heart rhythm aware. So once AF is detected and diagnosed, then the first treatment, as many clinicians call it, is anticoagulation. But there's an error immediately that we start calling anticoagulation a treatment, because it doesn't make the patient feel any better. It doesn't take away the symptoms. So all too often patients say, well, I stopped taking that medication, or I kept going back to my doctor, but I don't think he heard what I was saying. He just gave me the same anticoagulant or blood thinner or rat poisoning, as some of them call it. And I think it's important communication and education for the clinicians to educate the patients, for organisations such as ours to provide that information, support and education, but also educating the clinicians in the terminology that they use. That it's anticoagulation therapy. It will not reduce your symptoms, but it will help prevent an AF-related stroke. And again, not just calling it stroke, because obviously it doesn't prevent all strokes. And again, with patients, if they hear AF-related stroke, they're more likely to adhere to their anticoagulation therapy and understand why they're taking something that doesn't make them feel any better, but it's more of a preventative treatment, if we want to call it treatment. But then it's important, once you've had a diagnosis, once you've been anticoagulated to reduce your risk of an AF-related stroke, what are the next steps? And all too often, patients are not accessing the next steps. At the AF Association, we have so many, I mean, tens of thousands of inquiries a year. Patients, I am taking my anticoagulant, but I don't feel any better. What else can I do? So I think it's important, again, it's all about education and awareness of the treatments. Is it going to be a drug treatment? Many primary care physicians are unaware of ablation, for example. They may refer for cardioversion, but are not aware of ablation. And research shows that the sooner you have ablation in your journey with AF, the greater your chances of having almost a full recovery from AF. So I think it's important that we detect AF with a simple Know Your Pulse campaign and access to digital technology. We protect against AF-related stroke with anticoagulation therapy and the education as to how, you know, a clot can form in your heart and travel to your brain, so that patients understand why the need for taking this medication, and then to correct the irregular heart rhythm with access to appropriate treatment. And all of this must be done involving the patient at every step of the way. It should be a joint decision with the clinician and the patient suitably educated on AF and the options, so that they can have an informed discussion and ask the physician why he or she may be recommending a certain treatment, and is this the most optimal treatment for the patient. And I think if we detect, protect and correct, then we will definitely perfect the patient care pathway and improve treatments for atrial fibrillation. So we've said it's a challenge for the welfare system. Yes, it is. But I believe there are, excuse me, there are some very simple steps that we can take with awareness, information, support and education to improve outcomes for all patients with atrial fibrillation.
Thank you very much, Trudy. Very interesting to hear your point of view and the point of view of the Association of Patients. Let's move to the next presentation, that it will be given by Felipe Atienza, and we will leave the discussion for the end.
Hello, good afternoon. Well,
Hello.
thank you for being there. I'm going to present the results of the artificial intelligence-driven platform for atrial fibrillation and stratification, the AFFINE project. These are the members of the project that is led by me.
Felipe, we are not seeing your screen.
Oh, sorry. There you are. Are you seeing it?
Yeah, we see it now.
Okay. So I was saying that this project is led by me, working together with Maria Guillén from Universidad Politécnica de Valencia, Blanca Rodriguez from Oxford University, Carlos Cabero from Atos, Professor Francisco Fernández Avilés from the Fundación para la Innovación en Biomedicina, Josep Luis Falcó from Genesis, and Andreu Climent from Corify Care. This group is held and is led by the full-time project manager, Mulena Albertos, who is also in this call, and with the support of people from AT Health, Cristina Bescos, Julia Palma, and Claudia Navarro. This is one of the education meetings that we had together with a group of people that is attending the Master in Electrophysiology at the Gregorio Marañón Hospital. As you already know, patients with atrial fibrillation can be treated in different ways, either using drugs, cardioversion, or ablation. But the way we are going to use these treatment tools, it's very rough. We can either choose a drug or decide to ablate, but there are no clear clinical ways to decide which should we do. Clinicians do not know what to do, and they have no aims, a way to predict how the patient is going to do better with treatment. So in certain way, the clinicians are blinded to the treatment and are trying one strategy after the other until they finally end either converting AFib or failing in the treatment of atrial fibrillation. That is the problem that is getting tired physicians, and it's also getting tired patients because they are undergoing many different procedures that quite often are unsuccessful. So the way we designed this protocol, the AFFINE project, is to deliver a non-invasive medical device based in hardware and software tools that may help clinicians to evaluate how the arrhythmia is non-invasively before we decide to give a drug or to perform a treatment, with the aim to predict the probability of the efficacy of the therapies that we already have available. To that, we'll obtain non-invasively ECGI imaging, and we will combine this data with data coming from the mathematical modeling area, clinical data obtained from many thousands of patients, and introduce this data into artificial model to predict how is the patient going to perform. So the way we're going to conduct this study is to obtain these non-invasive imaging recordings, to combine this in silico populations data, and to obtain the clinical history of, as I said, thousands of patients, to introduce them into an artificial intelligence model to recognize the probability of success of the different strategies that we can obtain, giving us the probability of the most likely successful therapy and being able to treat better the patients, and that will lead us to be happy because we perform successfully the trial. The patient will be very happy also, and the system will benefit from this successful trial. The thing is that patients have been characterized from the late 90s in paroxysmal or persistent patients in a classification that was delivered by Professor Camp several years ago, and it was very useful because it enabled us to treat patients in a simpler way that everybody could understood. However, the problem with this classification is that sometimes the easy patients, that is the paroxysmal patient, not always convert to sinus rhythm during treatment, either using drugs or ablation. And we found out using our ECI imaging tool that sometimes the behavior of atrial fibrillation could be as complex as you can see here, with many areas driving out from both atria. This patient underwent AFib ablation, and the procedure was ineffective. On the contrary, some persistent patients that are well recognized by physicians that are more complex and ablation is less successful, sometimes can be driven by easy drivers based on a simpler area of the atria that, when targeted with ablation, can terminate atrial fibrillation, as shown in this slide. So this technology, ECGI mapping, enable us to predict non-invasively the likelihood of being able to terminate atrial fibrillation. Our aim before was to combine the information obtained from these ECGI recordings with the clinical data obtained from thousands of patients and with the information, in silico information from computer simulations, to be introduced in the artificial prediction model to decide and to validate these results in a clinical trial, to develop a business model, and to try to have market access with this tool based on the work developed by Genesis and Clarify, and finally to transmit this advancing knowledge using different educational programs to both patients and clinicians with the support of the Fundación para la Innovación en Biomedicina. Therefore, this is the way we have followed during the last 20 years, and we started from the very basic area of basic research and translational research to develop proof of concept studies that brought us to put together this group where we join computer science, clinical data, and ECG imaging to put together a tool developed by Clarify Care that will enable us to hopefully have market access and being able to communicate this information both to the general public and to the physicians treating AFib patients. So this is my last slide, just to trying to summarize what has been the evolution of atrial fibrillation during the last 30 years. In the 90s, atrial fibrillation was barely treated, very difficult to treat, and the work of Iceberg opened the possibility to introduce catheters to treat the atrial fibrillation, but with low success at that point in time. In the early 2000s, Biosense and other companies introduced invasive navigation systems that enable us to successfully treat atrial fibrillation. However, the proportion of patients that was unsuccessful and couldn't be treated properly is still very high. And we hope that from 2023, most patients will undergo non-invasively mapping to be able to analyze and to get to know the possibility to successfully treat atrial fibrillation or not to treat them and decide other different treatments besides of ablation with a catheter. Therefore, thank you for your attention.
Thank you very much, Felipe. And now we'll move to our last speaker, Daniel Engler.